discussing mitral edge-to-edge repair cases today, and it's my pleasure to introduce Dr. Catherine Tang, who's one of our structural imaging fellows, and who'll be reviewing 2 cases of M-tier, after which we're going to go over some didactics.
Thank you, Dr. Faza. My name is Dr. Tang. I'm one of the ECHO Fellows. Welcome to MMI. I will be discussing 2 M-tier cases for us today. 2 of most of the common scenarios we'll encounter in the cath lab. I'll start with a functional MR case. Case number 1. 76-year-old man presents with to Valve Clinic with recurrent heart failure hospitalization. He has a past medical history notable for ischemic cardiomyopathy. The LVEF is 35 to 40%. He has NYHA class 3 symptoms, and he has a history of CABG back in 2007. During that hospitalization, he had a TTE echocardiogram done, and it showed a reduced ejection fraction. And as you can see that the inferior lateral wall here is a bit hypokinetic. With the color Doppler, it's very difficult to assess the degree of MR, but there is some degree of MR here. Moving on, this is a zoomed in view on the left side for 4-chamber with color. Again, it's very difficult to see. You can see that there's color, but it's difficult to see the trajectory, and looks like there's an eccentricity to it due to the wall motion abnormality. However, on the right side, this is the Doppler on the pulmonary vein, and it shows that there's a systolic flow reversal in the pulmonary vein. So the reader concluded that it's very difficult to assess the degree of mitral regurgitation and recommended further assessment with other modalities and clinical correlation. The patient presents to Valve Clinic. He was started on more GDMT, guideline-directed medical therapy for heart failure, with Lasix, and the medications were titrated to max tolerated doses. From there, after 3 months, we decided to repeat a TEE to better assess the etiology and severity of mitral regurgitation. On the left is 4-chamber view on 0. That's the first thing you will see on the TEE on 0 degrees. And we liberally use a color compare and explain for those TEEs. And I just want to go over the TEE protocols we usually use prior to mitral clip. You can see that the posterior leaflets is a little bit restricted, and there's quite a bit of cutter flow, and the gradient was about 2. Moving on to 60 degree. 60 degree is a very common, we will use a lot of 60 degree views over here. On the 60 degree, we use the X-plane and to assess the leaflets morphology. And you can see that the leaflet itself is not coapting completely. So there's some side to end coaptation there. And when we put on color, yeah, granted that the big jet is actually in the central where we're seeing the malcoaptation is. Further on 60, we also explained, and on 150 is usually where our grasping view is, and that's in DASLI, that's the usual area where we assess the posterior leaflet length. And overall, when the posterior leaflet length is more than 1 centimeter, we felt that that was a technically feasible strategy for us for M-tier. At 60, it's also a good time for us to assess the appendage and also the pulmonary vein. In this patient, the pulmonary vein is blunted. 60 is also a good area for us to do a good 3D. But the good foundation of 3D is good 2D. So in this patient, we obtained 3D over here, and clearly there's a A2P2 central jet, central posterior directed jet. Moving on to long axis. Again, this is pretty close to the grasping view, and we're completing our assessment, making sure that that's where the base jet is. So Based on those assessments, we decided that the patient has severe mitral regurgitation caused by functional MR and caused by the ischemic cardiomyopathy as well. So we refer the patient for MTR evaluation. On the day of the procedure, it's very important to repeat what we just did for the procedure and making sure that things can change in between the time we do the pre-procedural TE and the time that we do the procedure. Repeating what we did earlier, 0 degree, 60 degree, and important to do a CW, making sure that we were able to assess the baseline gradient. In this case is 2. And at 60, we'll also assess the pulmonary vein flow. Over here, there's systolic flow reversal in this case compared to last one. We repeated a 3D, and for this patient, it hasn't changed much. Still, there's A2, P2, a large posterior direct to the jet. And the posterior leaflet finding is still 1.06, so very suitable for MTR evaluation. Also very important is for us to assess the mitral valve area by 3D NPR. And in this patient, we did online, and it was 8.45, and it's well above what we felt it was acceptable. And usually above 4 centimeters squared is where we felt that mitral valve is technically suitable for MTR. By the time we quickly finished all the pre-procedural protocol, the proceduralists at the time already have gotten the access, and they have the wire from the SVC, and they're ready to come down to the IVC. So over here, they'll go from superior SVC down and try to do like a posterior superior puncture. So this is what we did over here on 2D explain, and you can see the pointer, but posterior, anterior, that's where the aorta is, you want to avoid. And also you don't want to be too inferior or posterior, and that can cause pericardial effusion as well. So after we find the ideal spot, we also wanted to check making sure the height is acceptable, and 4 centimeters, above 4 centimeters, where we find that's an ideal spot for MTR procedure, where you can have enough heights to maneuver the catheter itself. So we measured this, and then we felt that that's acceptable, and we also reconstructed with a 3D structure. Over here on the right side, where the dropout is where the fossa is. How we made it happen is that we actually decreased the gain, so you're able to see the fossa. And over here, we can directly see how they puncture and cross the interatrial septum. Also very important to directly look at how they cross the interatrial septum and the catheter is crossing, making sure that there's no hematoma, no tear, and we need to guide them, making sure that the catheter is directed to the right direction. For example, on the right, where the red arrow is, the guide is very anterior, so that was a point that you will tell them that you're a bit too anterior and you need to readjust. After setting up, then the proceduralists will open the clip, and they'll check the gripper, making sure that grippers are working. And we throw on some color, making sure that that's where the worst jet is. We also assess the orientation, making sure that you're directly at the A2, P2 area, so you're not off axis. Once you get everything ready, that's when you cross, because once you're going under the valve, it's very difficult, or it's more difficult to do those maneuvers. So we wanted to make sure we're at the right trajectory, right orientation before we cross. So on the right side, we quickly switch to a dedicated 2D view, where that you find the longest arm possible, and making sure that you can see both leaflets and both long arms. Then operator pull back the catheter and the device a bit more, making sure that they have the both leaflets, and they drop the gripper. That's when we say that it's bouncing, meaning that the leaflet itself is tucked in within the two of the arms itself. And then they close the arm itself, and on the right side you can see that those are good tissue breach. That means that it's a good grasp for itself. So we really want to make sure that happens, because otherwise there could be a detachment as well. Oh. Apologies for the green screen, but what do you think of the result, if you can see? Right. So there's still quite a bit of residual MR on the medial and lateral side. I'm not sure why does this. So we released arm and decided to change the strategy. So at this point, we felt that the one clip is not enough. So we wanted to move the clip more to the medial side, and then add on to another clip more immediately lateral to that. So we'll release that and move the device a bit more medially, and repeated the procedure. It looks like those are better. Okay. Better now. So on 3D over here, after the first grasp, and we confirm that the majority of the residual MR is actually from the lateral side, not from the medial side. That's a successful clip 1, and that sets stage for us to do the clip 2. Again, repeating what we just did. First, we make sure that we well position the guide, and we open the clip, and we check the orientation. And once we make sure the orientation is good, we cross the valve, and we check the orientation again, making sure that we're where exactly we want it to be. In this case, it needed to be very close to the clip 1, so that there's no regurgitation in between the clip. And then we switch to dedicated view and confirming the grasp, and close the arms. So this is the final result after 2 clips. And you can see that there is a small residual regurgitation, but we felt that that result was more acceptable. Yeah, so like I mentioned in the pre-procedure process, everything we did, we actually redo it during the procedure every single step. That includes first clip, while the clip is not released, we do the gradient, everything. And then we release it, check it again, and then we do it again for the second clip. I just kind of shortened it, making sure that there are not so many steps that's involved. And the final gradient for this procedure was 3 millimeter, and the pulmonary vein has went from systolic flow reversal to systolic dominant. After that, 2 clips were deployed. In the end, it's important for us to show that there's an interatrial septum there's an iatrogenic interatrial septum that could be having interatrial shunt. And if it's left to right, then we'll leave it alone usually. And if it's right to left, we will close it with the ASC occluder device. Post-op, the second day, the patient got a TTE, and we can see that there's a very well-seated clip. two very well-seated clip. The final mean gradient was about 4, and there is very little residual MR. Somehow it's not showing here. Okay, so moving on to case 2. This is a case of 61-year-old woman admitted for severe MR and for decompensated heart failure. She has a past medical history notable for severe pre- and post-capillary pulmonary hypertension, RV failure, obesity, and severe MR. When she is hospitalized, she got a TTE. On the left side, on 2D view, you can see that there's the anterior leaflet flail, and it's not coapting, it's going directly into the left atrium. It says it cannot play media, but overall, by color Doppler, it shows that there is very severe mitral regurgitation. On the right side, on the left side, actually, you can see that the RV is very big and the RV functions very reduced. On the right heart cath, it also showed that her RV systolic pressure was almost 100. Moving on to the right side by color, there is a significant PISA over here without even baseline adjustment. With color, and there's just color everywhere. However, it's mostly from A2 flail that should have been showing on the left side of the TE, but it's not showing. On the still image, it's a better understanding of the pathology of this patient. On the 12 o'clock is your aorta, on the left side is the lateral side, and on the right is your medial side. And where you can see the prolapsing is the A2 area, and there are actually 2 areas that's kind of prolapsing into the atrium, almost like a cleft. We went up to 110 higher degree and showing our grasping view. And again, the big PISA, it's probably diameter is more than 1 centimeter and very clearly at least severe, if not torrential mitral regurgitation. And posterior leaflet length is 1.1 centimeter. Mean gradient for this patient was 4 millimeter mercury, and there is systolic flow reversal of the pulmonary veins. Also, as part of the protocol, very important for us to check the mitral valve area, and above 4 is where we would like, ideally. And this patient, she has a 7.9 centimeter square. She was sent for a mitral clip, MTR evaluation, and she was sent down for the procedure during that hospitalization. And on the left side is the very first picture we got, and you can clearly see the anterior leaflet flail, and that was also confirmed by the long axis view. When we're grasping, it's important to not just grasp the cords, but the leaflet itself. So the anatomy and being able to see the leaflets is very important. We looked at the 3D again, and the pathology is unchanged. The anterior leaflets is kind of separate into, the A2 is kind of scallops is separated into 2 pieces, and they're both flailing. So the strategy for a clip for this patient is that since it's very difficult to just use one clip to fix both of the leaflets flail, so we decided to do a 2-clip strategy. This is the first clip landing zone, about 117 degree, and the posterior leaflet length is 1.1. Very suitable for MTR. And given her severe pulmonary hypertension, RV failure, she's not a good candidate for any surgery. So remember, that's the indication for MTR for degenerative disease. Reassess the gradient, that was 3, similar to the TEE that was done pre-op, and there's systolic flow reversal. on the right upper pulmonary vein. In this case, we directly jumped into using 3D for the whole procedure in terms of the transeptal puncture and the valve and clip assessment. And we're looking at the fossa directly where on the left side is the anterior where the aorta is, and on the right side is the posterior. And lower over here, down here is the mitral valve. And what we want is the mitral valve to be horizontal, or you're just looking at it, and you want to measure from the top of the fossa to the mitral valve annulus. And we felt that that area was very acceptable, so we took it and did transeptal through the 3D, and where you can directly see the catheter going through the fossa itself. Using 3D, we can also directly visualize the interatrial septum and making sure that while they're advancing, there's not a lot of tenting, and also that they're going through the right trajectory and there's no tear. Once they get to the right spot, they open the clip and they check the gripper, making sure they're working, making sure they know which side is which. And then after that, they kind of lower, move the clip itself down a little bit closer to the valve, making sure the orientation is good. So the difference between the middle and the right is I think that the right, they kind of try to point towards on the medial side and to target the medial side of AU2. On the left side, the video is showing that right before we cross the valve, we found where the clip itself is, the arm is the widest and the narrowest, and that we felt that that would be our good landing zone, and that would be a good place to cross. However, while we're trying to cross, and we have trouble to find where exactly the arm is the widest. So that raises a question of whether the orientation has changed or something has happened, and why is that we weren't able to see the clip itself. Yeah.
What is the unique procedural danger in this particular case that we don't often have to worry about, but in this case you're showing, I don't know how this ended up, but basically a question for you or Isa. The danger that exists here that doesn't exist in a lot of other cases.
The tear of the leaflets, but that already has happened.
It's the entanglement of the ruptured cords. So you've got an A2 flail with two cords flying around, and they can actually go up and wrap around the delivery as you're trying to maneuver the device in place. So just to mention that, here you're going to be incredibly careful on where you position, because if the cord goes up and tangles around, you can never undo it. And then the only way to get off is to deploy. So you can't move medial or lateral, you can't change orientation. So by the time you get down close enough, you got to be very certain that that's where you're going to go, because you can't, if you get tangled, you can't move other than let it go.
That makes sense. So the question was that the patient has pulmonary hypertension and RVSP was close to 100.
Yeah.
Yes.
So like, is there mean pulmonary arterial pressure or systolic PA pressure beyond which we don't consider mitral clip or is no longer safe? Because some guidelines, if I'm not mistaken, beyond 70, they excluded the patient.
I think so. Yeah. So this patient, she had a right heart. You're right. So I think, is it 70 or mean PA pressure? Yeah. So I think, does that mean 70? I believe that's usually the cutoff. But for this patient, she was as high as 100, and then she was optimized later, and then went to like a RVSP as high as the 70s, systolic though. So like Dr. Little mentioned, that we were very careful in terms of making sure that the orientation is what we wanted, and we double checked the orientation again, repositioned, and crossed. And on the left side is where that we find that the arm is the longest, and we pull back the device and capture both of the leaflets. Now, there is still significant mitral regurgitation lateral side to it, which is not surprising, but good thing is that on the left side, on the medial, on the medial side, we didn't see quite a lot of regurgitation anymore. So we did the assessment one more time, the gradient, the pulmonary veins, the leaflets, making sure it's a good grasp, and 3D with color. And there's severe lateral MR, and the mean gradient went up to 6. So at this point, the question will be, well, where is the 6 gradient from? Is it a time to stop? So we did a little bit more evaluation on this case, and the mitral valve area for this patient, remember, is about 8. And on 3D, you can clearly show that there's quite a big flail component of the A2, just lateral side to clip 1. And with color, it shows that it's quite significant. And what's useful is that on the ventricular side of the 3D, where the color is, and we can clearly show that the majority of the regurgitation is from the lateral side, but not from the medial side. Given that, we've decided to continue our strategy and put another clip right next to the lateral side of a clip 1. Similar procedure, we'll position, we cross the guide and open it, and we'll position it and then cross it. And here's another dedicated on the left side, dedicated grasping view, making sure that you get both of the leaflets, and then you grasp it and then close it. So after that, we confirmed that it's pretty good grasp, and with color, difficult to show here, but with color, there's very little regurgitation, and it was in between the clip. But we felt that that's as good as we can get, especially that we tried as much as possible to move the clip 2 close to the clip 1. And then we went back, and it looks like there's actually 2 small jets lateral to both sides. The mean gradient went down actually to 4 millimercury, and the S1 has resurrected to S1 dominant in the pulmonary vein. So we felt that that was a successful procedure, and we released clip 2 as a result. Similar to prior evaluation, we do have to do all the evaluation for the clip again. In this case, we do have to look at the interatrial septum. And given the elevated RVSP, the operator decided to close the interatrial septum with the ASD occluder device. On the left is over here, it looks like an umbrella. That's one side of the ASD occluder device. And then they later will release the other side. Post-op day 1 TTE shows that very good results. The clips are well seated in the positions, and there's very mild MR, and mean gradient was 5 at heart rate of 74. Two-month follow-up, the patient reports improved symptoms with good functional status. The repeat TTE showed improvement in RV function and pressure, and the patient continued the cardiac rehab, and overall is doing quite well. Thank you.
Do you remember the gradient after we released clip 1?
It was, I want to say it was about 6. Oh, the question was, do I remember what the gradient was after clip 1?
Yes, was released. Because sometimes when you're holding a clip with tension,
Yeah, it was about 6, I want to
6.
say.
And after we placed clip 2, it went down to
2-4.
4. When do you usually close the ASDs after emptier procedures? If you can review it with the fellows in the room.
Yeah, so in general, we always assess the iatrogenic interatrial shunt. We know that there will be most likely a left to right shunt, but if there's a right to left shunt, we generally do close it. Yeah, so yes, the patient, if have severe TR, if you increase the flow to the right side from the left to right shunt, and the severe TR can get even worse too. That's a consideration. In this case, it was more also because of the RVSP, and the operator decided to close it preemptively.
Exactly. So it's important to evaluate TR and PA pressure as part of your MTR evaluation, because that gives you hints as to whether or not you're going to need to close that ASD.
So I'll just comment on the two cases. So you showed a lot of 3D. Zoom 3D is the format, showing from the left atrium down, and obviously here, that is how we do a lot of these cases. There's variety across the country. Some people use, nobody uses 2D exclusively. Some people use a lot more X-plane without a lot of 3D. Some places we use NPR a lot, more than we do. There's no right or wrong answer. It's just whatever you're comfortable with and your ICs are comfortable with and people understand in the room. So we've kind of evolved this very 3D focused version of it, of these cases, but there's variety around the country. But the steps, as you've shown, are exactly how we do it.
Mm-hmm.
A couple things just to emphasize. You showed at the beginning, more so in the first case, the importance of getting these shots set up. And we've talked about that a lot in these imaging conferences for the fellows to understand, is that sort of 60-degree horizontal annulus is everything. And I say that because we get a lot of referent TEs from other places. And these are done in the community, and they may be done by people who aren't level 3 echo or don't do a lot of these screening cases. And invariably, on the 4-chamber-ish view, the LV apex is way off to the left, the annulus is canted at an angle, the X-plane is useless, and the 3D is terrible. That's the standard default referent T that we get. And so, you guys, how do you fix it? How do you get a horizontal annulus? What are the tips? Because that's what is really the workhorse image for all these cases.
I say from my personal experience, I'd say that clock, the probe itself, can sometimes help orient your heart, making sure that the probe is, making sure the heart is more horizontal. Not sure if retroflex sometimes help as well.
Yeah, it often can, and often you're too deep, so sometimes pulling the probe back, playing with the wheel. It's not true that you can't mess with the wheels in the esophagus. You can, you just have to do it gently. We've learned that in the tricuspid space because we do a lot of probe manipulation in the same esophagus to see the TR than we do for the MR. But I would encourage all the fellows in the room who are doing screening TEs, really practice getting your annulus horizontal in an X-plane. Not just one view, drop the X-plane. If it's horizontal in both views, that's perfect. That'll guarantee you a beautiful 3D, and you can do all this stuff. But if you can't get the annulus horizontal, you'll never get these pictures.
Great. Thanks for your comment.
All right. Thank you so much, Catherine, for the excellent presentation. So we had a case of functional MR and a case of primary or degenerative MR. We'll just go over some screening tips, indications, and procedural guidance specifics. So remember that as part of your MTR evaluation, you want to identify your mitral regurgitation etiology, which can be divided into primary versus secondary. Primary is where you have your perforation, clefts, prolapses, and flails, and secondary could be either due to functional ventricular dysfunction or atrial dilation. And there are multiple transcatheter mitral valve repair devices, some of which are being studied under clinical trials. The ones that are currently approved are the edge-to-edge repair devices. And like Dr. Tang showed very nicely, we heavily rely on the 3D surgeon's view of the mitral valve to facilitate communication in the cath lab. So we're talking to the interventional team in a unified manner. And this is your 3D surgical view where your aortic valve is marking your anterior border, your atrial appendage is marking your lateral border, so you see a Watchman device here to help you, and your septum is that medial border. And the scallops closest to the medial side are A3, P3, and those closer to the lateral side are A1, P1. And like Dr. Tang and Dr. Little emphasized, you want to get optimal 2D imaging to get optimal 3D imaging. So 3D imaging is not the solution to poor 2D images. You want to make sure that the annulus is horizontal. You want to adjust the depth. So you don't need to see the whole ventricle when you're doing your 3D view of the mitral valve. You only need to see up to the leaflet tips. You want to adjust the focus so that you're focusing on your mitral valve. And this is an example of that imaging acquisition. So you want to make sure that your annulus is included. You want to include your aortic valve as an anatomical marker. And then this is the view that you get after you rotate your aortic valve to 12 o'clock and tip over the image. This is a patient who was referred to us for MT evaluation. And again, like it was emphasized, a lot of centers rely more on 2D imaging, but this case also kind of emphasizes what 3D images has to offer in addition to the 2D imaging. So from here, you can clearly tell that there's a flail posterior leaflet. And if you do the 3D, then you can appreciate that flail posterior leaflet at P3. But in addition, there was an anterior cleft. So 3D can unmask some pathologies that are otherwise not revealed by 2D imaging. And this is a study that was published in JACE in 2018, where around 1,000 patients with unexplained MR were referred for TE, meaning by TTE, there was no evidence of prolapse or flail, there was normal left ventricular size and function. And those patients underwent TE, and 3% of them using 3D imaging were identified to having a mitral valve cleft. Again, emphasizing the role of 3D in looking at the mitral valve. And as part of the pre-evaluation for MTER, we rely on 3D imaging to obtain the mitral valve area. As Dr. Tang explained, we'd like that area to be more than 4 because that decreases the risk of causing any mitral stenosis with MTER devices. And using 2D imaging, it's really hard to tell when you're at the plane of the leaflet tips to do your planimetry. So with 3D imaging, you can set your area at the level of the leaflet tips, and that allows you to measure that 3D mitral valve area. Same goes for 3D color. Using 3D color, you're able to go to that vena contracta area and measure the area, and that also helps you evaluate your MR severity. These are 3D images identifying the two primary MR etiology. This is primary with a P2 flail, see the ruptured cords. And this is functional MR. You see that the posterior leaflet, actually both leaflets are tethered and there's annular dilation. 3D can also tell you if you're dealing with a focal pathology versus multi-scallop pathology. For example, this is a case of Barlow's disease where you have multi-scallop prolapse compared to the focal prolapse here. And don't forget the commissures. We can have pathologies in either the lateral or the medial commissures, and 3D imaging can help us look at that specific segment of the valve. For 2D imaging, you have to rely on off-axis views to be able to see the commissures, but 3D kind of shows it very nicely. Again, I don't want to just repeat the same thing, but the role of TE as demonstrated by the cases was to identify the pathology, confirm the severity, evaluate the suitability for the intervention, and then guide the intervention and detect any complications in the cath lab. And for primary MR, MTER is approved for patients with high or prohibitive surgical risk with favorable anatomy. So this is in contrast to secondary MR, which we'll talk about. So you need to have, the patient needs to have high or prohibitive surgical risk. So the conversation with the surgeon is very important. And this is kind of a figure showing the favorable and the challenging anatomies for MTER. So what the straightforward cases are where you have A2 or P2 pathologies, central pathologies, where your area is more than 4 and your gradient is less than 5 or 4. And when you have short flail widths and gaps, and where you don't have any calcification in your grasping zone. Those are the straightforward A2, P2 pathologies with no calcification and a sizable valve. It gets more tricky when you have severe Barlow's disease, you have multiple jets, all the scallops are prolapsing, or if you have calcification in your grasping zone, which would make it more challenging to grasp the leaflets, or if your mitral valve area is smaller than 3.5 and your baseline gradient is more than 5. But this brings up an important point to consider is that your gradient is driven by the area and the flow. So oftentimes you could have a borderline or high gradient with an okay area, and when you actually reduce your mitral regurgitation severity, your gradient will drop. So that's why it's important to take the gradient into consideration as you're looking at your area. So it's both the area and the gradient, as flow can increase your gradient. And this is a figure, basically. You don't need to know all the specifics, but it shows you that imaging, your baseline imaging, can help determine which device is going to be used for the intervention. For example, the mitral clip device comes in 4 sizes. The short ones, the NT and the NTW, are the shorter ones, shorter arms. The W means that the clip is wide. So we have a short clip, short and wide. XT is long, and XTW is long and wide. And based on the pathology you have, based on your gradient, based on your area, based on the location within the valve, if you're dealing with medial jets versus central jets, that helps you decide the clip choice. So for example, if you have a flail pathology, you have redundant leaflets, you have a large valve, you can use the long and the wide clip, the XTW. If your area is borderline, your gradient is kind of borderline high or the higher end of normal, then you'd use a shorter clip or a narrower clip. So again, just a figure to show you that your baseline assessment when you're doing a TE can help guide the clip choice during the procedure. And as Dr. Tang showed, the procedural guidance starts with transeptal puncture. You have your short axis view showing your anterior side, and this is your fossa ovalis. You always want to puncture in the fossa ovalis. And you want to puncture posteriorly and superiorly to allow room for catheter manipulation. And you want to be about 4 centimeters above the mitral annulus. An example of the transeptal puncture here by biplane explaining. So your needle is posterior, away from the aortic valve, and it's superior, closest to the SVC. You cross, we use 3D, but you can also use biplane if you have good images. You have a case of P2 flail. You see it by 3D imaging. You advance your guide catheter and your clip. Position the clip perpendicular to the line of coaptation. This is very important. So here, you're aiming at A2P2, so you want to make sure your clip is perpendicular to the line of coaptation at A2P2. You want to do all these manipulations in the left atrium, because once you're in the ventricle and you start manipulating, then you risk chordal entanglement. So that's how you minimize any drastic movements we do underneath the valve. So you optimize your position in the left atrium, close your clip, advance it to the left ventricle, and that's where you try to minimize any movements and grasp the leaflets. And these are 3D images showing that tissue bridge between the anterior leaflet and the posterior leaflet with significant reduction in mitral regurgitation. Some cases are very clear. You look at your color Doppler and it's clearly mild or trace, but some can be more tricky, and that's why we also rely on other non-invasive and invasive hemodynamic measures to let us know that we have significantly reduced the LA pressure as a marker of MR reduction. So here we look at the pulmonary venous flow at baseline, and you can appreciate that there's systolic flow reversal. And after the procedure, we had systolic forward flow. It's still blunted, but there was systolic flow in the pulmonary veins. We also measure the LV stroke volume using the LVOT from the deep transgastric views, and any increase in your LVOT stroke volume, specifically if it's more than 20%, signifies significant reduction in mitral regurgitation. And this is the view that shows the clip orientation in relation to your line of coaptation. So if you are aiming for A2P2, then your clip would need to be around 6 to 12 o'clock. I don't know if you can see my mouse. Probably not. Okay. If you're more medial, then you want to be 11.5. If you're more lateral, to stay perpendicular to the line of coaptation, so you're not getting side bites of the leaflets, you want to be around 1 and 7. So determining the location of the jet that you're trying to treat ensures that you're able to orient your clip perpendicular to that line of coaptation. This is a case of P2 flail, but there was also mild mitral annular calcification. You can see that by 3D. And as part of the baseline assessment, the area was 4.5, so that's favorable. The mean gradient was 1, again, that was favorable. Despite the presence of MAC, which can sometimes be challenging in certain cases, we were able to grasp those leaflets just distal to the area where there was the calcification. The green boxes are back. Okay. It's frozen. Any questions so far as we fix this? Yes, Freddie. I can repeat your question if you.
Yeah, so I would like to learn a little more about how you measure the flail width and gap in.
So we rely on both 2D and 3D imaging to determine the size of the gap between the anterior and the posterior leaflet as a result of the flail. You can also measure that on 3D, and same for the flail length. So combination of 2D and 3D.
Thank you.
Just a commentary on that. I mean, those were super important numbers in the Everest trial for the initial inclusion of the study. At the time, there was only one clip, the short, thin one called the NT currently. And the gap widths and the gap height were important then. Practically, they're not now. We don't really need that. What you need to know is you have a long enough posterior leaflet. As long as the posterior leaflet is long enough and with enough experience, and you can use multiple clips. So the gap width becomes irrelevant because you can just add clips. And the amount of flail, the flail height, you kind of wait till it comes down in diastole and you grab it. So those features were very important initial experience, but I would say both those things are less important now.
Yes, for the Everest, they had the NT clip. So since then, we've had the NTW, the XT, and the XTW. So for this case, we were,
Sorry.
Please go ahead.
I have a question too. So we were talking about the hemodynamic parameters after the mitral clip. So we mentioned about a couple of things. Are there cases where like one hemodynamic parameter is not great, but the other two is good? So do you go back and try to do adjustments, or you just want all of them to be?
That's a great question. And actually, we also look at the invasive LA pressure. So we have the pulmonary veins and we have the invasive LA pressure, and we look at the V wave and the mean LA pressure. So we incorporate the invasive and non-invasive hemodynamics. So in cases of functional MR, where these patients have significant diastolic dysfunction, you could start with like a super blunted S wave, but you do achieve significant reduction in your MR. You have a reduction in your V wave and mean LA pressure, but your pulmonary vein also remains blunted. So there are multiple factors to consider. So you want to take the invasive, the non-invasive assessment, and the residual MR. One thing that I will show in a second is you can also do a 3D vena contracta area. Again, another additive measurement you can do by echo to confirm that your MR is not significant. So it's a combination of invasive and non-invasive hemodynamic measures. And sometimes when you're getting your transgastric images, you're not really aligned with the LVOT, or it's hard to obtain this signal, so you have to kind of rely on what you have. Yes?
I had a case report where they couldn't get to 4 centimeter height from the mitral annulus and still stay within the fossa walls. They went superior and they went to the pericardial cavity and ended up with a diffusion.
Yes.
So you run into that you can't keep the fossa and it needs to be higher. And that time, how do you know, or how do you guide the situation?
That's a great question. So we try to stay in the fossa ovalis as posterior as possible and as superior as possible to avoid creating an atrial stitch. And that's where you go through the right atrial wall into the pericardial cavity, into the left atrium. You do your procedure, but once you pull back the catheters, then you end up with a significant pericardial effusion. So we try to stay within the borders of the fossa ovalis. By 2D, you can see the junction of the thick portion and the fossa ovalis. By 2D, you can see that as well. And some pathologies are more forgiving. So if you have functional mitral regurgitation, then the zone of coaptation is going to be below your annulus. So even if you're getting 3.5 from the fossa ovalis to the annulus, you still have about 0.5 centimeter to go into to the point where the leaflets go up. So that would be your total 4. If you have more lateral pathologies, then you could use slightly lower height compared to the medial pathologies where you need a higher distance to be able to manipulate the catheters that medial within the valve. So I would caution against creating atrial stitch, Dr.
No,
Bill. Any
you said
thoughts?
it very well. I mean, it used to be 4 centimeters, but it's not really that tight anymore. Depends on where you envision the clip's going to end up. So when you've got, as you said, a Barlow's where the clip's going to end up at the level of the annulus or above, you want an even higher puncture because you want to have room to maneuver. So then you want a 4.5 to 5. If you've got severe ventricular functional tethering and the clip's going to end up below the annulus, then you actually want to puncture lower. So you have to adjust the height accordingly. And as you said, a medial one, you need more height. A lateral one, a target, you can get away with less height. So there's all kinds of fussing around, but really anywhere between 3.5 and 5 is probably fine. And we haven't really had the risk or even a concern about puncturing out of the pericardium or into the pericardium and back in a very long time. I think, and 3D imaging
you.
helps a lot with that.
I'm liking the questions. Any more? Okay. So for this case, we were able to deploy the clip, achieving significant reduction in MR with an acceptable diastolic gradient of 2. Again, similarly, you look at markers of MR reduction, like a systolic dominant flow in the pulmonary veins after having a systolic reversal, and an increase in the LVOT stroke volume. This is your double orifice mitral valve if you use one clip. For the sake of time, I'm just going to show a couple of more cases. So based on everything we've learned today, look at this case. So this is a patient, again, with a posterior flail. You see that there's mitral annular calcification, there's calcification of the subvalvular apparatus, significant mitral regurgitation. This is not playing. This is not showing well. But the posterior leaflet was short, about 5 millimeters. The area was 3.4 centimeters squared. And you can see there's calcification in the grasping zone. So would you consider this feasible for MTR? So small area, short posterior leaflet, calcification at the grasping zone. This is when you would say MTR is not feasible and you would evaluate other therapies. This patient had a mean gradient of 4 at a heart rate of 79. It's a case of atrial functional MR. The videos are not playing. The area was 3.6. We evaluated the patient for other therapies like TMVR, which is being studied under clinical trials at this point, and the patient did not qualify for any intervention from that standpoint. So given the lack of other options, we decided to give MTR a try. And despite multiple attempts at using short clips, narrow clip, reorienting, repositioning the clip, we continued to end up with prohibitive gradients, diastolic of 9 and then diastolic of 10. So the gradient was prohibitive despite multiple attempts at device repositioning. And at that point, we did not deploy that device. We just took it out, and the patient was treated medically. So just to show that sometimes you try to predict what the gradient will be. The area is definitely an important part of it. And when you're in the procedure, you're going to have to try different strategies, moving the clip lateral or medial, being okay with some residual MR. So looking at mitral stenosis versus mitral regurgitation, looking at how old your patient is and what heart rate they would require if they're very active, and then kind of making that determination. Going back to the flail gap point that Freddie brought up, this is a patient, I remember this was a case during COVID, came in with a large flail gap, 19 millimeters. So based on the Everest criteria, which relied on the use of the NT device, this would have been excluded. Again, patient very sick, symptomatic, admitted for heart failure. And the patient was able to get XCWs at A2P2 and one at A3P3 with significant reduction in mitral regurgitation. So again, the use of newer devices that are larger, wider, the use of multiple devices can help you tackle some of the more challenging anatomies that were otherwise excluded in the past. One last note about TE and Barlow's disease, because it was an exclusion in the Everest trial. This was a paper published in 2021. It's actually a research letter that looked at patients with and without Barlow's disease and looked at the feasibility of MTR in these cases. So there were 69 patients with Barlow's versus 69 patients without Barlow's disease. And patients with Barlow's disease had longer procedure times and larger number of MitraClip devices implanted, as expected, where you have multiple multi-scallop pathologies. You would need multiple devices to tackle those segments. There was no difference in the intraoperative success, acute procedural success defined by MR of 2+ or less. And there was no difference in the pre-discharge MR being 2+ or less. But patients with Barlow's disease tend to have more significant MR at 3 years. So again, pathologies that were previously excluded can now be tackled with the newer devices and advancements, I should say, and also the imaging techniques. We definitely have more, but I think we're running low on time. Any questions? Okay, hope that kind of gave you a flavor as to what we look for when we're doing our baseline TEs in the Echo Lab before we refer patients for MTR. And we're looking forward to future discussions on tricuspid edge-to-edge repair procedures, which are the new kids on the block. Thank you.